Good afternoon, one and all present here. With immense pleasure, we would like to welcome the distinguished researcher and practitioner in the field of homeopathy, Dr. George Mathew. He is currently working in Nehru Homoeopathic Medical College and Hospital, New Delhi, as a professor and head of Department of Medica. With over 3 decades of professional and teaching experience, he has significantly contributed to the growth and advancement of homeopathic medicine. His academic journey, marked by a BHMS from Kerala University and an MD in Materia Medica from the University of Kozhikode, has set the foundation for his exemplary career. His dedication as an educator is evident in his extensive teaching tenure and his role as a mentor and examiner for postgraduate students across India. As a researcher, Sir has been involved in critical studies, including pioneering drug-proving projects and investigations into the treatment of respiratory diseases. His work has been widely recognized and published in national and international journals, adding to the body of evidence-based homeopathy. Notably, his contributions have been pivotal during the COVID-19 pandemic, with insightful studies on homeopathic remedies for both treatment and prophylaxis. Beyond academics and research, his leadership in shaping the future of homeopathy through syllabus development, expert committee participation, and journal reviews underscores his commitment to the profession. We welcome you, sir. Now, I request Dr. Mathew, Associate Professor, Department of Medica of Father Muller Homeopathic Medical College, to welcome Dr. George Mathew, resource person with the floor. Thank you, ma'am. We are really honored to have you with us today to enlighten us with your expertise and valuable insight. Over to you, sir.
Good afternoon, all. I know the afternoon session is not a good time at all for interactions, especially such a deep subject as God have been exposed to in the morning. So, how many of you have attended the CBDC UG? More than half of you. I think for you it must be at least we have a foundation for jumping onto the PG platform. For the others it may be a little difficult. But so I think almost all the general things regarding this new curriculum, this CBDC curriculum, has been explained in detail by Dr. Nehru. Certainly the medical education technology related things, especially what we have assistance to, that has been explained. I don't know how much you have imbibed that or understood that, but anyway, this is something which is going to be implemented, and always I think the thing is to take a step forward. So if we are all PG teachers and we have to do PG, we are all, I think, a lot of PG teachers also. So we are doing our PG. But this is a little different from what we have done till now and what we are trying to do on an experimental basis now. So I just start with so these main headings have been already introduced to the curriculum components. Only the name changes are there. So first, part 1 has 3 papers, part 2 has 2 papers. Part 1 is fundamentals of Medica, and then you have paper 1. Paper 2 is fundamentals of clinical medicine. Medica, we have the practice of medicine part of it. I think earlier that is something which was very much lacking in our syllabus. I've seen, I think only the Kerala University having a practice of medicine paper in PG. So when I discussed this with my colleagues in my college, they are saying CCH has nothing to do with it. They have written nothing about having practice of medicine. So you are coming out as a PG student and without any knowledge of disease knowledge. So you are not at par with any of the other PGs who are coming out in other systems. That's a good initiative to bring it back to the system. The third paper, of course, is research methodology and statistics. That also, I think, when we are having a separate department for this, definitely there will be a lot of inputs regarding what can be done regarding research and understanding of what topics can be taken for synopsis and dissertation and all these things can be improved upon. Methodology and statistics department in our college. And part 2 papers, paper 1 and paper 2. So this is the overview of the curriculum template. Already I think this is the so I'm just giving the headings only. So why we have only Medica as a reading subject. Then we talk about the interestable professional activities. I think that has been discussed in great length. So what is interesting, what is professional, what is activity, and what is domain, what is competency, all these things have been discussed in detail. So I'm just running through these things to touch upon that later on. Then we come to the topics. So earlier we had only topics. Now we have topic objectives, now we have topic titles, and we try to describe each of the competencies involved in the standards. So that's it. Then the difference, major difference, what I felt was the learning methods. Earlier it was more of a teaching method. Even though I think in many of the colleges we are having the flipped classroom experience. We understood what is flipped classroom. Basically, in flipped classroom, what happens, we are discussing about that in the peer-based learning. We come back to that. So in flipped classroom, what happens is that the teacher gives the resources or the learning material to the student, and the student will deliver the lecture or the discussion. Lead the discussion. Teacher is just a person who watches this. So that is already, I think, happening for many of our colleges regarding teaching skills. So we don't have a didactic lecture type of teaching in our colleges, especially when we come to PG. I think that is how we normally implement it. So here, but we have more of a learning method. So earlier it was more about teaching methods, now it is about teaching learning methods. So that is something which is needed to introduce and that has to be explored. Then the assessment group. So earlier all these things were different packages. Now teaching, learning, assessment all come interrelated. That is one difference. So in assessment again we have summative assessment subject, and we have the list of reference books. So I think you must have, at least few of you must have downloaded or gone through the curriculum document from Medica. So the list of reference books, the list of books for reading are also added. Then coming to the subject proper, overview of what we are trying to just glance through in our Medica PG course. So one is basically like Medica means we are dealing with the medicines, with the homeopathic medicines. So we are trying to develop a competency to explore these medicines in depth. So that is a professional. So when we say interestable professional activities, actually we say it's professional because it is something which you have to achieve through a particular period of time, and that through our training, supervised training. So that's why we say that. So we try to understand or realize the potential of our medicine and the application part of it. That is one thing which is approach in this overview. Then different types of Medica, we already have knowledge about them. We go into that in detail again, looking at their philosophical background. So when we study all different Medicas, we know all the different Medicas and their authors have their own philosophies, which is reflected in their works also. So and the different approaches how to study the Medica. So these are taken on a more practical level. That is the one difference which I would say. Then we come to the group study, where we try to develop a competency to generalize or understand the group characteristics and also how to individualize the members of the group. Then other topics, again we are doing one is comparative Medica, and another one is clinical Medica. So this is also very important to improve our proficiency as a proficient clinician for the differentiation of drugs. All these methods, these comparative, clinical, all aspects are equally important. So the competency has to be developed on that level. So basically, if you look at, we are trying to focus on all methods or techniques which try to draw balance between the artificial disease process and the natural disease. So that is what. When we come down to the basic staging, that would be which covers all these things. So for that, we are using different types of approaches to come to that understanding. So in part 1 syllabus, this is just a nutshell what we are going through in part 1. So we are the paper itself is fundamentals of social engineering. So we have the source books in detail, nature, scope, the concept, application, the philosophy, everything in detail is there. Then the symptomatology. So how to elicit the symptomatology, how to come to the drug proving, how to understand drug proving, and how to understand the application of drug proving. So then we come to clinical materials. Already that I mentioned about that. So that is again the construction, the concept, the philosophy of clinical material. Then physiology action effects. Already this is all things which are familiar to you, so I'm not going back to detail. Then we come to the mathematic understanding related to the clinical pathological action of the drugs. We try to understand the clinical pathological action of the drug and then try to understand the correlation with the miasm of the eye. Then the concept of causation, etiopathogenesis. Then the importance of significance of disposition, temperaments and constitutions. And the second paper we have the, in the third paper we have the basic principles of research and part 1 is constructed. And after part 2 we have the evolution of material. So there again is also comes the construction, utility, and concept of types of material, again concept, philosophy, then different approaches, biological system, circuits, do study. Then the comparative mathematical clinical application. So clinical application in different subjects like medicine, gynecology, surgery, how clinical can be applied. And lastly, some other things is nosodes and sarcos, their concept, their application. These are the main broad divisions you can say of topics given in two different subjects. And directly I am jumping to the EPAs. So EPA is something which is you already have heard a lot about that. So one of the things I just wanted to highlight, wanted to point out the major difference between what is the competency and what is the EPA. So EPA is not an alternative to the competency. So it is actually using the competencies and using and through the EPAs they are going to the future. So actually I think that was described very well by Dr. Muller in this class. So it is translating these competencies into clinical practice. So if we are achieving or we are getting the training to achieve certain competencies which are important for translating the EPAs into clinical practice. So that is the EPA is something which the competency is something which you are trained for achieving these EPAs and for translating into clinical practice. So that is the journalism. So there are elements of trust and professional, all these things are coming to be prompted. Now again, this is something about, I think we know the basic difference between competence and competency. So competency means actually, in competence we say like I am able to do something. I have the ability to do. So rather, when we say competency, I have the skills and the knowledge to carry out something. So that's a basic small difference between these two. That's how we can understand. So one is having that ability already. The other one is you develop the skills and the knowledge to do these things. So here we know how these three items, on the cognitive domain, the knowledge, the record, the understanding of things which we know, that comes from the cognitive domain, and the skills which we develop, and then the attributes. So these three come together to translate the competency into outstanding, we can say, outstanding performance. So whatever we are being given, that these three elements come together to help you to translate this into outstanding task which you are able to perform once you are trained to this. Here we can see how starting from a novice, who is a beginner, grows to an expert through the competency development. So here you can see the pyramid at the lower part, you know, the nose, starting with the nose. The nose starting with the part of the recall which basically happens there. So that knowledge is derived from the, you can see down the side, you can see that what you get from the lectures, from the textbooks, from the normal MCQs and all, that you get this knowledge of knowledge of what you know, say about what you know. And then the next level, which is knows how. So we know the reason behind it, we know how this happens. So that comes a little more when we have an application to this part. Like an MCQ can be a direct record question also, it can be an application based question also. So that is more than a lecture, can be into a discussion after a lecture or during a lecture. That can help you to understand about how or knows how that will be used. And the third one is more of the demonstration which we come with, shows how. So it shows how we can say this. Earlier I think I was telling you about this OSPE and OSPE, both these types of assessment, spectrum of assessments, and role play. So these are two examples you can say how the shows how translates into an understanding. Then the last one is actual how you do it. So that means you are empowered enough or you are skilled enough to actually do the thing. So that is when you have this EPAs coming, industrial professional activities coming. So these are all the the activities and assessments which are related to the knowledge on different levels and the skills how you are assessing. You can ask them if NCS doesn't have a problem, I can share. I'll discuss and I'll let you know. If it is okay with them, then I can let you know.
Even if there is one PB.
Yeah. So again we come to EPAs. So basically it's a work which we are assessing when we say about EPA, and this reflects a responsibility that should be entrusted upon someone with adequate competency. So competency is something which you should have to carry out an EPA. So without a competency, without acquiring a competency, you will not able to come to realize the EPAs. Then more detail has been mentioned. I will go into that in so much detail. Now we come to the details of infrastructure EPAs, mapping of EPAs and the domain. So I think one of the examples I have just taken to just see how this happens in topics which are and the semester wise. I think semester wise we had some discussion regarding how this is carried out. I think we'll have a positive discussion, and I think if there are things which have to be taken up, definitely I will be the first person to take it up with the MSH also. Because these are all new things which are implemented, and even I think medical education technology itself to is a new, to many of us is a new thing which is implemented. So there are a lot of ifs and buts there. So that we have some things which are lacking or something which are contradictory to what is mentioned, and we definitely take it up. So I'm just looking at the running through the course objectives. So in Materia we have some detailed course objectives are mentioned. So one is again coming back to what are the headings I have mentioned. So source books we have discussed earlier. So the philosophical background of source books. So this I'll take for as an example when we come back. Then the cumulative group study, that is another one, construct and demonstrate the group study in clinical practice. Then under application of clinical area, the practice and domain profile analysis. Then acute chronic drug portraits of clinical area and different sources. Then case receiving, so that is coming to the patient, case receiving for the purpose of clinical and personal understanding of patients. Documenting the encounters. We are taking down the receiving the case, we are noting down the case or processing the remedial diagnosis. Then the data what you have already got, you have documented the data, you collate the data for other data, definition of what is the clinical problem, and again the person diagnosis which is important. Then go for the investigations, recommended investigations if you are not done, and then when you get them, you interpret the investigation formulations and diseases at different levels. So if you need lifestyle changes, that is definitely has to be implemented in specific illness, disease-related changes and the nutrition level and planning the implementation from the understanding of the disease. Then again, arriving at the solution through differential study of the nutrition. Then outcomes from the intervention based on comprehensive management. Then coming up to again a little more advancing gather appropriate evidence to advance patient care and modify. So if you want to started with the medication and then you modify the medicine or the remedy, then think about that how you will carry that out. So that's also important. Then the next stage where you go for a second opinion or referral or expert advice to improve the quality of care which is at present being given. Then the next few things are actually whenever integrated as well as do the right to indicate. So you have to make a presentation of the clinical environment. So this is very important, especially regarding the PG student, because whenever we go for PG bypass, when you go to the bedside, we see a lot of students just reading out their cases. So they are not able to assimilate. So when you need to go for a bypass at the bedside, clinical bedside examination, so you have to first of all understand the case, assimilate the thought process in the case, the main findings of the case, and then you have to discuss why you have, what medicine you have arrived at, what is the logic behind the medicine, what is the logic behind the medicine, what is the analysis. So you have to have these thoughts, random thoughts which are reading out from the book, should be in an order, like arranging your thoughts so that you can. So this is something which I found is important when it comes to an examination, especially for the Viva and the practical bedside examination. It's very important. And we have to make an oral presentation of the clinical environment. Then you are handing over a patient. So you are giving to somebody else and you are shifting the patient to someone else. So what is the guideline? So I think now we are all in many of our colleges are in NABH implementation, and also I think now most of these things will be touched upon in our patient care. What are the things to be looked at in patient care? So this also is coming in. So how to responsibly carry out a transition from one to the other. So how to take, how to refer a case, how to transfer a case, all these things are. Then how to be a part of an interprofessional group. That means it may be from outside also we have to people to interact with. So how to maintain your stand, how to keep your views and able to air your views in interprofessional. Then application of ethics in professional practice. Then formulate, implement and assess teaching plans. So that is again, so learning happens for a PG student the same time they are teaching. So that is something which we had a discussion on earlier. So when they should teach. So normally when a PG student comes into college, the first day they are start assigning, we take the syllabus. So now we have understood that there is a time. So what I generally do is like now what I follow, I think it should change. So when they come to college, I think they will be at the level of the HMS only. So basically they should know what, suppose you want to present a drug in, you want to take a drug in a class, they should have an idea regarding what all references they should essentially for reference. So normally sometimes if you ask us a student to go and take a drug in a particular class, he may just take, he or she may just take the keynote and go and then read it out and come back. That also can happen. Or they take the boring and go and come back. So what all books they should refer, reference books, and what all they should essentially include when you are trying to understand it drug and present it to student population. That's very important. So this formulating, implementing and assessing teaching plans based on the clinical environments. This is one more point. This is the last group of place. So then comes the research part. And then conducting research relevant for continuous quality improvement of the services using different. So this is again, I think we have left out certain topics for discussion again. How the synopsis, I think we had this discussion in our PGs and PGs. Like in Materia, what should be a synopsis? It's very important because in organoid we have a complete number of things to look at when you decide on a synopsis. But in Materia, what should be the topics of a synopsis? We can have a discussion regarding that also, time topics and research relevant to Medica, how that comes, that is also important. Then for identify areas for growth. What are the areas where you can grow? So that means in relation to the books you read can be different ways. Can be e-learning, can be different books you are exposed to reading, with the CMEs, all these things can be there. So as to get a mastery of the subject. That is important. So I think I was very happy when once I had the opportunity to take a class for the Kerala University of Sciences. We had, the university has done that. Till what I know, because we have done updates on every subject. So that is very interesting, because when you have updates, you have a lot of interaction, you have a lot of gray areas at least which will be discussed. Even though we don't have answers for everything, you can at least have discussion on those gray areas when like-minded people come together. That's very important. So updates are very important. So whenever you have a chance for updating yourself either on as a part of CMEs or going to other classes or practitioners, listening to lectures and doing practice, getting understood. Like when I went to NIH for I remember Dr. Winston is here, he was also a research person there. I went as a candidate, as a delegate faculty. So there Dr. Sarkar was taking a class, so he was class. So he had a book with him. So that book I had never seen. That is from pharmacology and so something like that. So many books at least we are not even aware of that still exist worldwide. So that may be introduced to us like just when you are having with contact with people, research persons, or some other things. Maybe even your juniors may introduce you to new learning material. So that's important. Then lastly, when this EPAs are like the BGs are exposed to this EPA, they are doing this EPAs, they learn all these teaching learning techniques. They will get the know how to apply these teaching learning techniques also in UT and in future when they become the teachers. That is also. So this is regarding just the EPAs. Now come to mapping. I will pass this things to know. Mapping only one example I will do today. Now time we have. So mapping, we have 6 domains where we have this competencies where we have this. So knowledge and scholarship, patient care. So you can see from the domain system where patient care is coming, that is important. Where only orientation is there. So according to the EPAs, we can understand which all parts are involved, which all domain competencies are involved. So here we can see the first EPA which I have already mentioned earlier. Explain the philosophical background, plan and construction of different books, different ways from the source books. So basically it is not a patient care involved. So you don't have a case, you don't have a patient care involved. So you have the knowledge and scholarship part is important, then we have the orientation part. But the patient care, the communication skills, the professionalism and the other things are not there. So depending on the type of EPA which is involved, we can understand what all competencies are also involved. That is right. So if you look at the next one, this is something which is dealing with the clinical practice. So construct and demonstrate the utility of group study in clinical practice. So when we see the application in clinical practice, definitely we have patient care coming, we have communication skills coming, so you have to communicate to different people, to the patient, to the bystander, all these things are. So to the students, to the bedside students, all things are involved. And then we have the practice based, so it's a case oriented discussion. So that is 2 examples. So you can see that in the 5th one, you can see all the elements are involved, all the domain competencies are covered. So because it's the same activity, so that's how you can see that. And so I'm just going to pass with this recommending interpreting investigation. There also you can see almost all the domains are covered. So because there's the application part is coming. So there again is a good opinion now, and then all the domains involved. Oral presentation, we have almost all the except the patient care, other things are involved there. Now we go to the, so just I wanted to show how this, so this is our idea where we will have a lot of doubts also. So that is the semester-wise table of EPA levels and competency levels. So we are looking at one EPA through the period of the 3 year which the student is going to. So we have different levels of EPA. I think we show the next slide which is more comprehensive. So in EPA level 1, so when we say EPA level 1, there is no activity. The student is not enacting an EPA, he is not doing anything. He is just there. He is just there allowed to stand and observe. So this is something like we are talking in first year when we have this case taking in Medica, first year CBDC we have. So they are not actually doing it, they are observing what is happening. Listening to what I think that is happening. This observation part is the most important. So that a silent observation, just being present there and observing, that is the EPA level 1 and not enacting or anything. And level 2 actually starts with the persecution. So there is a direct proactive supervision. The teacher will be there in the same room and there will be supervision definitely going on. At the third level, you can see they carry out with indirect supervision. So the supervision is gradually, you can say, direct supervision is gradually taken out of the case. So that's how the grading goes. Then we go to the fourth level, he is allowed to work unsupervised. So it's totally left to himself. And the fifth level is the confidence in the ability to do EPA himself. That translates into the ability to provide supervision to the juniors, to the students below him or the juniors. So that is the higher level of the EPA. So you can see the supervision from an unguided level to a guided, guided level to an unguided level. That comes to the 5 levels. So this is one example, one of the examples I will be trying to show. So we can have a discussion at the end regarding these things. So semester-wise table. So here I have just taken the first topic, that is the first EPA. So the philosophical background, the plan and construction of different homoeopathic sources. Different homoeopathic including the sources. So we are looking at all these different aspects of different sources. So that's the. So in the semester 1, there is the department 1, we have 3 semesters. So semester 1 to 3. So in the first semester, basically the plan, philosophy and the construction from the source book is started with. In the next semester, so the clinical Medica part is added to it. And the third semester, the commentary. So the whatever is there regarding the commentaries, regarding the source books, that will be added. So you can say one element is added to each of the semesters. So you can say that is how this happens. And then in the part 2, 3 semesters, in the fourth semester you can see the keynotes and the differential Medica is added and the remedy relationship is added. So that's the next level you can see. And in the next semester. And the fifth one, there the understanding of the subject is almost, you can say, complete in that way because all the different components have been added. So he is able to demonstrate this particular thing to be a particular topic in an effective way to the juniors and also able to guide the juniors regarding this particular topic. So that is coming in the last one. So you can see 2, 3 in the first semester it is 2. So there is no 1. So they are not allowed to practice in happen anywhere. So 2, 3, 4 and then the 4 continues for the next semester also. And then the last 2 are 5. So 6 we had 6 earlier. Sorry, 5. So 5 is the last one. So last 2 semesters are 5. So here I think the components are added one by one to the semester, and at the end the student develops a overall round or a broad understanding of the subject so that he becomes able to guide the others also, juniors in this particular topic. One more so this is construct and demonstrate. This is the second one. Construct and demonstrate the utility of a group study in clinical practice. This is being also we have seen. So here we in the first semester is again the concept in philosophy is study and how to build group indications. So I think what was going on earlier, so earlier people used to, like students used to come to the teachers and ask how to do a group study. So earlier concept was, if I was asked, definitely I would say, I would recommend only clinical Medica by EA, that is your foundation stone for group study, and the rest is ideally, if you want to do a group study, you have to list out the remedies from exhaustive list of remedies, and then you have to read from whatever books, importance of the books which are mentioning about this individual drugs you read. So when you read an individual drug, like for example, you are reading the individual drugs, you can some certain characteristic pop out automatically, and in that popping out, you can say there are some differentiating factors also in there. Because when you say Mercury and all the others, they have certain characteristics of them, but some certain remedies may have which have a differential or a contrast indication. So that this individual variation also may be happening in a particular field. So here the different aspects in the second semester. So we have whatever part of concept philosophy we have understood and indications we have developed, we are going to organize the data. That is happening in the second semester. And the third one, we build the conceptual image of the group indications. And then in the part 2, that is the fourth semester, we go to the application of the group indications. Different. So we have the cation and the anion. So I think I don't know how many colleges do that type of a study normally. When I have some reservations regarding cation and anion studies because we don't have definite information regarding this from any of our source books. So these are some things which we derive. So but these are actually things which we have to discuss. So while I think somebody, when I was doing my PG, one teacher came to our college. I will not mention the name. So he recognized the whole case and he said these are some elements of magnesium, these are some elements of phosphorus. So we give magnesium. So I'm not a person who goes around with that. So if it is magnesium, it is magnesium. And we have conceptual image of magnesium very clearly in our mind. So that cannot be added one plus one, that does not translate into two as such. So but this is something like, yes.
Sir, in particular, you are not giving out any particular textbook for following.
Textbooks are there.
But those are the actually we have followed in the history only, sir. From that we have to derive it.
Basically, if you ask me regarding
Yes, sir.
any particular topics in Medica, the thing is we have to read books and we have to develop our own understanding from these books. Because there's no particular, now I think if there are some guides to recommend certain books, you read this book, you will get this. So that is not, I think the best idea would be like when people used to come to me and ask regarding group studies. So I would say you list out the remedies. First of all, you list out the remedies as very comprehensive, either you go to synthesis laboratory or to any class period analytical laboratory, and you list out the remedies only, whichever group you are on. Then you read them from what books you can get. So if you read them, the main thing is you read them in a way to understand what all things are common. So we have certain common shared characteristics of them. And then there are some differences definitely that will come out in the reading. So this is the only way to, I think I'm not a person who will advise you to read this book, you will get this. It's not possible. Because it's a big, like these things are all spread out through, and whatever book I would recommend in group study, I would only, because I at least try to read some of the books. I don't know how many of these books are actually written by people who have written them, because the material, the mistakes which are there. So at least if you read Fahrenheit, you know that this is stuff which is definitely a basic foundation is there. So from that that is your foundation, then you can read. So that doesn't mean that you should not read other like controversial books are also there. You should be open. What I would say is you should be open and try to take what is scientific from there, because you can incorporate in your practice of your teaching. So if you are taking something which you cannot justify to yourself or you cannot incorporate into your teaching or into your legal practice, then it will be difficult. Because basically being a teacher, you should be able to communicate to your students also what you are doing. Simply, you cannot say like today is Monday, so I'm giving Mangalore, today is Tuesday, so I'm giving Sina. That's not possible. The students are much more, I think they are after us. They want to know why, and exactly why they want to do. So the basic prescription you will have to definitely at least it is 2 points or 3 points on, maybe it's only 2 points, but that is maybe observation. So it's not that you have to give them 6 different headings or characteristics to show that this is sepia or like I said, maybe a rapporteur mortality, maybe an understanding of determining which are so different things can be used for research. So there is this books for reading is I think I have listed out as we are a group. I'm not trying to think myself. We have a group of 3 people there. Myself, Dr. Sopenport from NIH and Dr. Muller from Medica. So he's in Almira and he was the person who was supposed to present this discussion or lead the discussion. Yes. Yeah, the fifth one, the fifth semester. Which one? Different calculation, that one. So that is. Five and 6 will definitely come to the next one. So the clinical practice part is coming now. Semester 5 and 6. So we, in the semester 4 part, the clinical practice element is not there. We are not having a patient. This actually to build an indication. It's not actually you are not dealing with the patient or you are not involving a patient care. The last two, semester 5 and 6, there we have the actual clinical practice where we have a patient and you interact with the patient. You use this knowledge and then you apply to the patient. What you have just mentioned, this one is to build indications for medicine. That is the next step where you actually go to the application. So this is you develop using these two, cation and anion, to develop a user's drug picture, and then the next semester is the semester 5 and 6, where we have the next level where you have the clinical practice knowledge, where you apply it on the patient. So there actually that is what I understand, where the patient interaction comes. Where you everybody has to add to it, you can add also.
It is a part of character as well as a practice. Because in every part we are getting the character part, but in every part we are getting the practical aspects. So that third one I am not understanding. The next the way to the individual practice.
What I understand from this is to build an individual indication means like you are getting, you are arriving at a portrait. Using these two different elements, you are arriving at the individual remedy indication. I think what you have told about natural and false, that must be a combination type of methodology which you are using. But you are arriving at that, but you are not exactly using this on application in actual clinical practice. The actual clinical practice comes in the next two only. Here is we are developing a database or we are developing an indication group of symptoms or indications for this individual remedy based on the anion and the cation element.
Because it is good at every part too.
Yeah.
Because everything in part 2 is not application level. So you are also, but both semester 4, what is the result? It's clearly not an application level application. You're supposed to know something about cations, supposed to know features, or phosphorus group features, and both are there in that one first.
Yeah.
Or calcium and phosphorus in the calculation.
Yeah.
That can help you to enter the remedy portfolio.
Yeah, that is your just.
So we say that part 2 is application, but in some cases it is not. Cannot say that.
Maybe that's what I think. Part 2 meant if you are taking for granted that the whole of part 2 is completely clinical based. So there are elements still that this is something which you build a picture, but the actual application comes only in the next segment. So here we are just developing an individual remedy, understanding using these two things, and then so some overlapping comes. I think the knowledge part comes into the this practical the part 2 also it comes. So it's not a watertight compartment. You cannot say part 2 may only clinical and the other part only knowledge base. You cannot say. So some of the elements come here. That's why I think this seeming overlapping is coming. So here I think the last two only have that actual clinical practice coming, and this other one is building the portrait. So you're building it, you're getting a database or you're getting a group of symptoms, characteristic indications for a remedy using these two cation and anion groups. That is what we do. So I think these things are things which you have to be threshed out with the water. Small areas where you have. Now we come to the topic content and description. So here, this is one major difference where we are shortlisting or we are taking out one topic each, and then we are trying to understand in this framework. So we take a topic overview, then we have certain competencies which are to be achieved and learning outcomes from each competency. So these include 3 levels. So we have a knowledge level, we have a skill level, and we have a reflection level. So that also one example I can just show you. So once you achieve these competencies on knowledge, skill, and reflection levels, then you will get the learning methods for this particular this topic for the topic how what are learning methods are to be utilized, and then the assessment of this particular competency, how we do this assessment, and the assessment tools if any. So assessment and assessment tools and that's a review. Then the prescribed textbooks for understanding this one. So every topic, I think we have been trying to understand that in a comprehensive framework so that we can understand where it is given, where we have to read and that. Then the domain of the finally comes the domain of knowledge, where we mapping also happens. So knowledge happens, the question here and knowledge happens here. So I take one example and then we can understand that. Before that, so I just look at the paper 1, paper 1, topics and topic objectives. So basically, if you look at this paper 1, you can see this is about the fundamentals of intelligence. So that is the structural aspect, psychological and causative aspects. All these are looked at in the paper 1 topic objectives. And here the evolution of practice in the mental level, in the body level, the human body, to understand the clinical material. So these are things which come in the topic and topic objectives. So here we can see the topic numbers here. So topic number 1 in paper 1 for the part 1, that is the foundation. That everything deals with the foundation of the source books, the understanding of the source books. And 2 deals with the comparison of Medica and with the other systems that comes under 2, and 3 comes under the symptomatology, improving application. 4 is symptomatology again, and there we specifically is going to Oriental, Parisian, etc., Tyler and Medica, and also PFL. So some books, prescribed books are mentioned for just as a guideline for understanding this concept. And then in 5, we look at the application of symptomatology Medica through the study of the clinical pathology correlation. And this is a action. So this I think one example I will take up in the similar example I will take up in the problem-based question. And in 6 we have the physiological action. So specifically mentioning Bird and Mental. This looks by Bird and Mental. And so to understand the functional organization of the remedies, we have to all these things understood in that particular area. In 7, niacin, and again relating this niacin to the pathological action of the drug to the niacin, but correlation is done. In 8, causation, the whole concept of causation that is explored through pathogenesis, expressions of Medica, expressions and symptomatology, so how the causations are manifested. Then in 9 we have basic psychology, and here element 10, that is in the concept of mind and mind. So 3 elements, 10 guidance of mind. Then 10 development of the mind, maturation of the mind, or evolution of mind from childhood to old age. 11 disposition, constitution and temperament. So this these are things we have already discussed. Only the topic numbers are going. And in 12 we have the critical thinking and evolving drugs of time. Then in part 2 we have again I think 13 to 27 we have topics come on part 2. So here again evolution of Medica, sources, types, approaches of study, then study of elements. So in between actually we have the lists are also given. So basically the general topics are meant to be studied in relation to the medicines also. So normally earlier we had syllabuses, this is the list. This is the list of articles, this is the list of rare remedies you have to study. So here one major difference which are found is that the lists are a guideline for you to apply these general topics, to understand these general topics using the remedies in this list. So it can be like in the different part 1, part 2, paper 1, paper 2, all we have different lists or list of drugs to be, right? I'm not displaying that list here, but if you go to the document, you can see that document, you can see the list. And the groups are mentioned, the different annual groups, time groups, chemical groups, all the different lists are there. Even the polyplus rare remedies, and we have also been listed. So using as a guideline, you can build your questions through the general topics. So, general topics and the list of remedies can be utilized together in training. Each and every person is just a guideline. Each and every that's up to you. So how well you can utilize this list in comparison in mathematics, in conditions, so because it's a huge thing. I cannot pinpoint and say this is very easy. Even trying to apply a part of this will be very difficult for us. As a beginning, it will be very difficult to apply even a part of it. So just yeah. So here we can see this topic numbers are guidelines when you put the question, like the theory, when you work out the theory, when you work out the practical, then the topic numbers are involved. So you pick up the problem based from a list of, like suppose 1 to 11 is the list of numbers you have given. From any of these, you can pick up the problem base. So I'll come to that later. So you can understand how just example. So these are all almost 27 objectives are there. 27. So all the things which we have mentioned earlier, normal pictures, subgroups, then even other techniques for understanding Medica. So Medica we can arrive in different ways. Directly studying Medica and then rapidly studying Medica, that is another way of again arriving at Medica. So that all will come under this study of drugs as per the list. So 20, 30 to 27 will come in the part 2. Then part 1, paper 2, that is the clinical medicine part. So there we have the introduction to the practice of evidence-based medicine, developing a basic legal approach. So there are I think 5 topic numbers are there. Studying cardinal manifestations of disease through the pathophysiology, using Human's classification. So here actually, I think in our curriculum, I think 2 examples are given. One is I think dyspnea, and the other one is pain. So how do you explore pain? So when you take up deep understanding of pain, gastrointestinal bleeding. One of the examples only have been discussed there in our curriculum document. So the others are like depending on the institute, you can develop your own types of clinical symptomatology and understanding. So suppose you are taking pain, you can understand what are the causes of pain. So if you are taking a down pain, or you are taking gastrointestinal bleeding, what is the cause of gastrointestinal bleeding, what is the type of bleeding, what can be the pathology, what can be the diagnosis, and what can be the medicines taken. So you arrive at you explore the symptom in all from all different sides. So that then you finally arrive at Medica after exploring the participants part and understanding the clinical pathology operation, and then you come to the Medica part of the pain. So what are the pain and medicines for pain and all. So this actually individual symptomatology you can explore therapeutics using I think dyspnea and pain. Individual examples have been in this. So different specialties are taken on different topics. So we have taken pain and dyspnea as examples to develop this third topic now. Then concepts of nutrition disease, mathematical assessment, interpretation. So these are all things which are common to almost all the other specialties also. Then I will just take, I think so here this is a problem, other subjects we have in one topic we have only one competency. So we have in one topic we have multiple competencies. So for example, this is the foundation of the first topic number. Coming in our paper 1. So there we have explained the concept of conversion method. That is one. That is the competency we are trying to explore. So we will understand this competency on 3 levels. That is the knowledge level, skill level, and the production level. So 3 levels that will help you understand this competency. So in knowledge we see what is the concept of Medica. Then we also see understanding the study of Medica. Then the source books. We will start the source books and try to understand. And in skill, we demonstrate the concepts at the bedside. So what are the concepts you are applying and then trying to understand this on the bedside, and reflection is you try to reflect on the or lengthy concept and philosophy after study. So that is something which you do after you have learned. So I think in the learning methods we have learned about reflective learning. Reflective learning is like you read something and then you write down something. That is this I was telling about you attend a seminar and then you come back and you give your reflection or you write down your reflection. So that is something which you assimilate and then you note it down or you document it. So that is something that comes with the reflection. So going through this knowledge skills and reflection, we can arrive at this competency, and then we next. So that is the second competency. So this is one competency. The second one is the scientific aspect. So here also the three levels are there. Knowledge, skill, and reflection levels are there. So the scientific aspect of Medica, science and philosophy of Medica, and the clinical pathological correlation at the bedside. So this then we come to the skill where actually we apply the science at the bedside, and then the reflection where you think on or you reflect on what you did at the bedside, understanding the scientific aspect. Then there's one more. This is the three components are in the first topic itself. That is government nature and scope of Medica. The scope and limitations at the bedside. That is the competency. And then we have the knowledge part. That is the what are the scope and limitations? Explain why we are applying. Then actual interpretation of clinical symptoms at the bedside. Then the skill of communication of scope and limitations of the patient's related. The patient comes to you and then you have to explain to the patient, you have to explain to the patient's relatives what, how. So now I think the patients which are coming to us are more knowledgeable than us regarding the disease diagnosis and the disease management part. So they do a full research and then come to the doctor to see whether the doctor has knowledge of this. So we have to be a step ahead of them and look at the patient's needs. So this communication to the patient is very important, especially for example, like if a patient is coming is diagnosed with cancer. So I think I heard that in Calcutta Medical College there is a module they are introducing in palliative care, just how to break the news of cancer to a patient and to his relatives. So that is a very important thing. You can just say that you have 3 days to live. You can finish with that. So that the patient may pass away after 1 day also, because that is the way you explain the thing to the patient. So the way of delivering a particular message or communicating the particular message, or especially regarding a crucial general diagnosis to the patient is very important. So whether you need to break this distribution account or only to break this, that's also a decision we have to take with you. So there are a lot of things which are involved when you are doing this type of skill of communication. Then this is a continuation of what we were saying earlier, the learning methods. So this study of Medica, these things basically you can see there is a bedside element is there, and there is a self-contained learning. That means you yourself are learning yourself, and you are taking a self-regulated learning means you are learning, and then the teacher can ask and see whether you are learning. So that also will cover under that. Library basis, we are using library resources to and then we are also include e-learning also, because now that is also very easily accessible. So e-learning, library based learning, and the bedside element also has been incorporated because that comes in the competency. Then the assessment, I have included certain assessment tools, that is short answer, assignment, viva, and OSCE. OSCE can be thought of when we have a clinical examination as a bedside is involved. Then we can think of OSCE, what is how Muller was saying about this, about the checklist, about the rating scales, and about OSCE. Especially in mathematics, I think it's a little more difficult to make out a checklist like that. So these are things which we have to work on a lot. Please take out at least one topic you have to take out and then see how you can prepare it. For example, if you want to take out history, take that topic and see how you can split it into components and see whether you can make a checklist of it. So because in this NABH assessment and all, I've got that this, for example, the nurse is taking an injection. So she's taking an injection, another nurse will be watching her and seeing that she goes through all the necessary with the that particular order. So if it is there only, then that exercise is complete. So whether that we can develop such a exhaustive and logical checklist that is yet to be developed. This is I think something which PG guides and teachers have to sit down and see how much we can do. So it's not so easy because we can just say that we make a checklist, we make a rating scale, and not so easy because there is shown that lots of rating scales are being done. Implement that is a little difficult, but at least I think we should take a step in the right direction. At least one step is there, then we can at least try to understand what are the problems involved in developing such a. Then the prescribed books is as per the list which we have given, so I will not include that here. Then the domain competency is a domain competency, knowledge scholarship, orientation, patient care, and practice based. Now we complete, so this I can again serve as one details, so I am not going so much in detail. So these are all the learning methods we are seeing. So there are basically two, one is individual that we are going to look at, another one is the group activity which we are doing as a group. So in the group activity we have all this features. Earlier I told you about the flipped learning. So flipped learning is something which we can definitely try and improve on that. So that will develop their communication skills also. So what happens is that they make a presentation with you. So in our college we can have class in our group. Suppose 3 students are there. We can have in our classroom also they bring the laptop, they can bring on the table and then they start reading from it. So I see that they present it in a interactive there's a chance of interaction where there's a big platform and they stand up and they try to understand what they're doing and questions are. So there actually a lot of contribution will be from the other students. Suppose 3 students are there. So what generally happens is that the student who has prepared will come, will prepare, will present. The others will just see as if they're seeing a film and they just flow. So what should happen is that the topic should be given earlier and then the others who are coming, they should be much more well read so that actually your discussion takes place. And then the comments and the intervention of the teacher that will help you understand the case and it will go better. That is what should happen. So I think these are small things which we can develop in our I think you can also share what you are doing, what type of learning techniques you are utilizing, you can also share with me sometime. So this is problem based. So in a problem based actually we are looking at something which we don't do. Problem based means we are exploring a problem. So we don't have any prior information about that topic. We are trying to explore that. So that is problem based learning. Then case based means you have a case in front of you and on that basis of the particular case in front of you are having the discussion. Brainstorming in a give a particular topic. So brainstorming can be included especially where we have this diagnosis, differential diagnosis. For example, we are taking a symptom of dry cough. So what is dry cough? So we brainstorm what are the causes of dry cough. So you can brainstorming again. This here you can understand this is a learning method and this is not a teaching method. So basically brainstorming, suppose there are 5 students are there. All the 5 students they put out their opinions forward, and the teacher just collects this opinion. He will not give any opinion of the teacher. Because he is not the person that say you have 5 opinions, I am reading it and giving mark for that. This is just a collection of or collating these opinions together. And he is just a wire reading, so he does not have any active role. That is why we say it's a purely a based learning method. Then we have website that we know what bounds we know, outpatient based and OPD based, and lab based means like those learnings which can be utilized using the lab. So for example, if you want to understand some things about liver and for example, you want to understand about the titration or something about titration of pharmacy, where you can take them to the pharmacy lab and see what exactly happens. So you can have a direct operation with the lab or direct approach to the lab and then see what happens. So that's a lab base. So it can be any particular topic you can utilize this method. Then flip learning and role play based conversation like we are having like a sketch or a drama.
Could you explain the problem based once again? Because that is there in the undergraduate CBDC also. Problem based learning and case based learning. So
Problem based basically what I understand is problem based is something which we have no prior knowledge. So no prior knowledge exists on the group of the teacher regarding this particular. So we are doing we are taking a topic about which we don't have any prior knowledge. And we are trying to explore that thing. So when we are coming to case base, you know this is a case of Huntington's.
Example, sir? Example from problem is.
So what we do for undergraduate, we are not very sure about the different tools. So case-based we give case. Problem-based we give case scenarios where there is some applied anatomy, some applied physiology, and of course Medica differentiation also. I mean that is what we do, but we don't know whether that is correct or.
The problem is what we had a discussion with Dr. Muller earlier. So what he was, because these are all medical education technology terms. That's why there is always even though we have certain things we are trying to implement, it's not so easy. So what he told was that it is something which we don't have a prior access to, information access to, and we are only exploring. For example, we are exploring something in a practice medicine topic in a class where they have not actually started with the practice medicine topics, diagnosis and all these things. We are giving a diagnosis and we are trying to, or we are just they will give their opinions. They are trying to explore together, giving their own opinions and then examine how I think more this will be applicable for subjects like practice of medicine, surgery and all. More
Sir, what is happening is that as information comes to the OPD, a new patient comes to the OPD. So we need to take the case and then do the diagnosis and give the remedy. So that is problem based. Case based is a case is there.
Case basis means that you have like a diagnosis, you have patient with the diagnosis and you have a prior information about the case and you have.
So I'm thinking, suppose for the areas where specific things are not mentioned in Medica. For example, whether you manage a case of poisoning with homoeopathy. So would that be a problem-based approach, because there are many issues to be thought of in medical legal. I mean, there is actually somewhere in Andhra Pradesh where somebody is treating snake bites with homoeopathy.
Yeah.
So that I'm asking whether that would be an example of a problem-based learning, where these things are not there in our literature.
So
Or management in emergency, road traffic accident or emergency cases, which we don't usually see that much, but which can be discussed. At least at the PG level. Why I was confused was the same thing is there at the UG level also, where we are asked to discuss 5 hours of problem-based learning.
just one minute. Based this same thing about what we told about problem-oriented learning, and something which you have information and you already have some access to information, and then you are trying to understand that further. So problem-based, what Dr. Nehru was saying was regarding this particular aspect. So he gave the example of a case of dry cough. So we are giving, like, taking out the problem of dry cough. So the students will discuss all the different aspects of dry cough, whether it's already the causations, all these particular things, and then exploring on that one. But I don't think how much of this will apply to in homeopathy. This particular topic is not very clear for me also, because Sir was telling, but actually when we came to the question paper layout, where we were asked to put case scenarios. So that's
What is a case-based study? When we are putting the case scenario here, the problem-based study, then what about the case-based study?
problem-based and case-based, not much of a difference, I would say. Case-based means like it's a case, diagnosis case.
There also we are giving one set of the case. Case-based study.
And how the
But where we are presenting a scenario, from there we have to arrive at the diagnosis, we have to arrive at the differential diagnosis, the remedial diagnosis, the differential diagnosis, the remedies, the investigations to be done. We're taking the whole screen through logically following the case to the end in the description, and that's what we do in the case scenario. case scenario. So we don't know. Like for example, I'll come to that. I'll just give you a case and then from there what all things can be asked regarding the particular case. So that I'll come to. That will be more clear. So these are things which you can. So all these things are not applicable in our. So there are many more are there. For example, if you are dealing with physiology, anatomy, or other subjects where we have lab. Then we have the other assessment or other learning methods are there which can be utilized for learning those things. But in Medica we don't have so much of only the case-based and the knowledge-based. These two things are what we have. So I think some of these are applicable, some of these are not applicable. So that way so almost all the other things are. So in the individual based, we have already discussed related learning, reflective learning also we have discussed e-learning. Space cognition is like we are trying to like give gaps and then repeat the same. So it's actually it's a memorization procedure. And deliberate practice is actually for this physical skills. So you know, for example, you are examining a patient, you know the respiratory system examination. So you do that again and again to develop that particular skill of examination. That is deliberate practice. So different things can be applicable to different aspects of this. So that is how you generally use this learning methods. Assessment, this is just assessment, not assessment method, sorry, so just assessment. So assessment you have both in theory and clinical, whatever also you have assessment. And clinical you have formative, summative and theory again. So I think we'll come to that in detail. So assessment again, tools of assessment. So we have told about summative, theory assessment, that all these things are basically know about. So tools are like MCQs. MCQs can be again direct MCQs, where your application based MCQs also can be there. Then short answer questions, assignments you can get, where the class is supposed to give a topic and get an assignment and then rate that assignment. Then Viva. Then this checklist and rating scales, these are all I think basically information here and website which we use this. Then this is the formative and summative assessment pattern which we follow in part 1 and part 2. So formative assessment means the internal assessment what we are doing. So first, so again I think that's almost a similar pattern as what we see in the UG exam test and all these things are there. So exam test in the 6 months of training you have the first term test and then 12 months again you have the second term test. And summative assessment, that is the university examination will be in the 18 months. That is the part 1 pattern of assessment. And part 2 is the theory. And then the part 2 will be 24th, 30th and 36th. That means the last interview will have the assessment of the exam. And the distribution of questions for theory based assessment. Problem based, we have one question of a problem based. So that we have seen example I think of that. So that is 20 marks. So 20 marks, how to think about a problem. So normally because we are not tuned to that. Normally we have 10 mark question, we have 5 mark question, or we may be MCQs also. But 20 marks, so 20 marks actually we should have a definite break-up of the marks. Like we can give 5 marks each, 5 to 4. So 4 parts for 5 marks each. So that can be utilized. Similar way you can break into marks. So that is a problem based of 20 marks. So one question will be there. And that is normally the first question will be the problem based 20 mark question. Long answer you have 4 questions and 10 marks each. Short answer, so the examples I will keep at the end of the long answer, problem based and the short answer. And in short answer you have 8 questions, so that will be long answer questions, 5 marks. So those will be 40 each and the other one will be 20. So that is a total of 100. So the only thing I am unable to understand is there is how you develop how the student develops a pattern of writing the examination. That is, we have the examination, we have the paper also, but earlier, like now we have a pattern where we have the ABCD sections. ABCD section means there is one essay in each section, there will be 3 short notes in each section. So like 25 marks in each section. So it's easy for like one essay will be half an hour. So 4 essays, 2 hours, and 5 marks for a short note. So 12 short notes, 5 marks, 1 hour. So 3 hours. But when I'm trying to fit this pattern or something of a similar pattern into this 13 questions is very difficult. And I don't know how the student actually is writing the exam will be able to finish the exam or do justice to this pattern of examination. So I think if there would be some MCQs also, that would have been better. This is the pattern which is being developed. So we have this 20, 40 example. And the thing is, from where we put the questions, there is the topic numbers which are coming in. So this is the part 1, paper 1 format, where we have the first question is the problem based of 20 marks, then 4 LAQ. So here you can see the first question is from 1 to 11. The topic numbers from 1 to 11 you can go through and you can select any from them. But there again there is another problem which I saw was that suppose you are not taking from 1 and 2. Suppose you are leaving 1 and 2 for problem based. Then that part is not asked in any else. Because then it starts from 3, 4, 5, 6, 7, 8, 9, 10, 11, 1 and 2 will be gone. So you have to definitely put one question from 1 and 2, otherwise that portion of the will be. So there are like that. There are some loopholes will be, and then the LAQ 4 LAQs are there that you can see 3 or 4 again this examples are given. And then SAQs 3, there are also the topic numbers are given. So similarly the part 2 paper 1 we have a similar pattern. Again the numbers are changed, but the pattern is the same.
Study of homeopathic drugs as per list, some 100 drugs are there and only 5 marks are there. So there is some, lot of underrepresentation as far as drugs are concerned.
I think the basic idea is that is there in the another idea. We will have to note down where all we have used lines. That is question number 18.
Yes.
Sorry, topic number 18.
Topic number 18.
Topic number 18. I think one more section was there where we have the list of drugs. So I think what either we have to change that or like take it to another section or we have to apply or we have to like basically these drugs are given as a guideline where you can apply whatever other topics are given there you can incorporate. For example, you are using clinical pathology and correlation where you can think of certain drugs which are related and then try to. So you can utilize this list of drugs as a reference point for whatever other questions you are framing. It's not that you are asking a drug specifically you need 5 marks. That is what you have asked is a relevant question. But the other questions also you should incorporate the drugs, the other drugs like different whatever ways you can incorporate the drugs in comparison or in differentiation, you can use that. So that is that list of drugs is the reference list for you to utilize in wherever you can utilize. So this I will take up that 18 now. Before part 2 before 1.
Part 2 paper 2 also, so it contains all the
list of drugs. List of drugs. 27.
And the total number of drugs are only 276 drugs are there. These only 276 drugs are there.
So here the main thrust is not about the content, but about the range which is studied. That's the basic thing. So earlier, like you asked, if somebody asked what is syllabus of PG, everything under the sun. So now also there is everything under the sun, but this is a guideline. Suppose you are asked about a particular drug, you can compare other drugs to that. Maybe outside the syllabus, you cannot say this is just like the syllabus finishes there. This is a guideline actually. That is what syllabus also trying to say. Don't take it as a thing to be implemented in completely in that way. So you take it as a guideline so that it can be improved upon.
Now we have a list of 400 plus drugs in the PG center. Now we have only 276 of
Yes.
registered drugs. Then what about the remaining drugs?
So the understanding of CBDC is what I am also discussing. This is something which I had a doubt when we had this CBDC. So what I was told was that it is we are not worried about the content. So there is a problem in that says because there are people who read extensively. Because I remember like in my first year when I was taught code of filing. So Dr. Nehru was the teacher. He would say Jetrova, I was just like hearing, it was like Greek and Latin. But once I started coming into the higher classes, I think these are still not in the PHMS syllabus. But by the time I reached PG, I think in the PHMS itself, when I was going through code of filing, I could see Jetrova, all these tests are already covered. So none of these are on the syllabus. So for a student who is inquisitive, so if we say about phosphorus dialect, these are the tests to be compared for. Like you will definitely say Tuja or phosphorus, definitely you say. But the rare list of tests which you are saying, we do not even not even familiar with the spelling of the name, just try to write down. At least 4 or 5 tests used to compare with that, all outside the syllabus. So that is something which an inquisitive student will take. Not all students will take. They will not even now the students are like that. Now if you go to the class, they will not even have their notebook with you.
Paper-wise you will not start.
Yes.
Paper-wise you will not start. Paper number of drugs are there. Paper number of drugs are there. That division also not given.
That is there.
No, sir. They are given only list of drugs, but division-wise paper they are not given.
The paper 2 is not there.
Only all.
Sorry, part 1 and 2 is there.
Part 2, sir. Part 2, paper 1, paper 2. Which are the drugs belongs to paper 1?
Paper 1 and paper 2.
This comes from paper 2.
So this not given. This so somebody, one of you can just note down the motions we have pointed out so that I can raise it. So I think representation of the taxi level in this system that can be changed. That should be I think modified. So now I will come see problem-based questions. We are discussing only. So problem-based question I think to prepare a problem-based question in Ogron is more easier. But in Medica to take a problem-based question is little difficult. So problem-based question as definitely there should be more or less 3 or 4 parts are there. So basically there should be a case scenario or a case study with the clinical information. Then questions like subparts, that's the description of the parts, where you are able to assess the clinical skills or understanding the location of the examination. Then this should involve critical thinking, and should cover the different competencies of the current topic. So here actually, if I show the example, you will be able to understand it. So this I have just taken one application of this is the paper 1, part 1, paper 1, 5th topic number, application of clinical mathematics to study of clinical pathological correlation. I have tried to frame something on the basis. This is basically a case scenario. It's not a proper practice of medicine based case scenario, I would say, but case scenario is actually we developed during the COVID times. So during COVID, when we had the examinations, we didn't have patients coming. So we had case scenarios given and then on the basis of the case scenarios question section. So this is one such example which I developed that time. So this you can just go through. A pale, sickly child, looking child, a 6-year-old child, presenting with flatulence and whitish diarrhea. The child goes into the finger into the nose, causing bleeding. His mother reports that the child gets up at night frequently for urination and also likes to come in water at night. He has a thirst for cold. So this is just a case scenario. So this is what I would say, this is just a material based case scenario. This has not much of practice of medicine elements here. But we can add to that. When you are asking questions, we can definitely add to that. So some investigations you can say the sugar levels are increased, urine sugar is there, pallor is there, melanitis is there, sphenomegaly was there. So remember, this is a material question itself. It's not a practice of medicine question. But I'm just trying to apply the what our questions can be thought of for that particular. So just divided in 4 marks. This can be again discussed and reframed also. Just an example I am trying to do. So what can be the probable diagnosis? That can be multiple diagnosis also. So what all can be the diagnosis? Like diabetes can be there can be other infections can be there, sphenomegaly is there, pallor is there. So you can look at the different diagnosis which comes up and what are the signs and symptoms which lead to your diagnosis. So it can be multiple diagnoses. I am not saying this is a single diagnosis. So because this is an imaginary case based on a drug. Again, I think human being will understand this drug also. Any guesses?
Sir, you are saying is an example of a problem-oriented question.
Basically, just basic. But what I have not tried to incorporate a lot of element, a lot of practice of medicine elements into that. Yeah, this is a basic problem, I can say problem-based question. That means you have components of investigations, you have components of trying to look at things. But it is basically constructed on a very
There is a 20-mark question. 20-mark question.
Sir, it is a problem-based question.
Sir, this is
Mark question.
Sir, just please go to the previous slide. You missed at the starting.
Sir.
This situation we are going to the
So this is a case scenario. So this is one topic number which I have given. Like you can see, 5. Topic number 5 is the application of children Medica to study of clinical pathology. So whatever we have, whatever information of the child, the disease condition we have got, whatever symptoms, whatever signs we have got, and how we arrive at the diagnosis, how we diagnose the disease, differential diagnosis, then the medicine diagnosis, what are the points, observations in favor of the medicine diagnosis. Just trying to approach it. But I would say this is basically a pure mathematical question. It's not actually a thing which I made just because I wanted to improve practice of medicine and other things. This is actually a pure mathematical question only. But you can take it on that level also, where you have findings, clinical signs, symptoms are there, and different diagnoses. So you can approach that in a different wider way. I think you know the medicine. Any guesses? That doesn't count. The part of the medicine is not very valuable. So this is the case, the symptoms, the symptoms and the desirable, whatever is mentioned here. findings. So the sugar levels are increased, sphenomegaly is there, meningitis is there. So this, and then what are the, it can be multiple diagnosis. That's why I just read what is the multiple diagnosis. It can be one or it can be two. Definitely, diabetes can be there. There can be other recurrent infections, other infections also can be there. And what are the signs and symptoms which will lead to your diagnosis? What is the differential, or what are the observations in this case which lead to your selection of the solution? Then identify the remedy, potency and dosage. So I've just tried it very, this is I think I would say it's a very rudimentary thing. It's not a full-fledged question. You can develop your own just for stimulating a discussion. I just made this question. Then the third is other remedies which can be thought of for differentiation in these types of conditions and how we differentiate between them. Then how will you manage this case? What will be the general management? How will you plan for general management? Considering the considerations diagnosis. So 5 marks each for if you are dividing, or you can have more elements added to this question so that you justify your 5 marks. If you feel that the question does not warrant 5 marks, you can add more elements also. This is just a basic suggestion for you can develop your own things with more illustration, with more diagnosis, with more clear-cut thing you can add. So this is just basically I have taken as it was from both. Same as we got randomly picked out and the findings which I have just made into the sections so that you can understand. So this is the basic idea of our problem. So that means you have a scenario-based scenario in front of you with signs and symptoms and on examination findings also. And then you think about what all things can be, how you can approach this problem, what can be the diagnosis, what can be the diagnosis of the drug, what can be the, when you can apply the miasm also, that what you would do, what can be the underlying miasm, how can you physiologically, how can you control the miasm. That also can be a part of the question. That also can be. So this is just one example for it. So similar other examples also you can develop around like reading, go through certain, let's see you can get an idea. Suppose you are getting, you are reading digital, you want to, like it's not digital, you can frame something like that as a middle age patient, 45-year-old or 50-year-old patient comes with urinary problems and then on exam he has tachycardia and findings are there. Then some other symptoms, one of the symptoms is one of the later something you can add. So you can highlight the pathological correlation with action so that you can arrive at that probable remedy diagnosis and then with other things. So this is just an example. This other this is an easy topic that way you look at that particular thing. This is the topic easy for you to understand in the case scenario. Then this is an LAQ just for your understanding. So the group study was one where you discuss the structuring of it. So how you LAQ question. So there's some. So what is the relevance in clinical practice? How can you use this group study in clinical practice? Or how do you arrive at the group characteristics? Is understanding. So example of a media you are taking. Then how these group characteristics are shown to media. So it can be any spider family, it can be the organism, any family can be taken up. Can be animal family also. And then how you use the repertory in other groups. So we are looking at in a comprehensive way the 4 or 5 aspects of that same thing can be understood. So that is that. So you have a 10-part question, you can even I think divide this into maybe 3 and 4 or something like that. You can divide that question. I think many of the universities already are doing that. The division of questions are there. The division of questions is important because otherwise students have ideas also about something which is not needed. So the division of questions is the part is also important. So this is just any group you can take it and similarly you can approach this question. Then we SAQ, 2 examples are this. One is mother tincture. So what is the concept of mother tincture? And the concept of mother tincture, how it's made, what is the utility of mother tincture, physiological action of mother tincture. So maybe you can take up one particular mother tincture and mention that also. That also I would say use this list because this final list actually I was not able to, all the correspondence was made with the individual study of efficacy of individualized homeopathic medicine, like diabetes. That was the normal study which was doing, and even now that has been going on different places. Now the next step is happening where we have efficacy of comparative study of the individualized homeopathic medicine versus a single drug. For example, if you are taking migraine, you can take iris rosetta. Just give me an example. So you are taking iris rosetta as a single remedy, and you are comparing to individualized homeopathic medicine. So you have two groups.
When one specific remedy is that of individual criteria, we can't compare because it becomes a bias in knowledge. None hypothesis will do, sir, when we are taking like this. If we are taking two specific remedies,
What I am saying is, this is what is being followed in many places. Like you have a comparative study. Earlier was a single group study. There was no comparison. The comparative group was done. And now we have two groups are the one where you have. So this actually recently I had a PhD protocol resolution discussion. So there the research expert was there. She was asking, how you can say individualized homeopathic medicine as one single. It's not a single remedy. So you cannot use that. That is one main thing. So we try to explain how the person, the PhD scholar try to explain what she does not understand. Because there you have a very clear, because there is enough confounding variables should not be there. You have a constant, it should be a constant. It should be one single medicine. So we are taking individualized homeopathic medicine, it is not like a group of remedies, any of these can. And you are comparing with the single medicine. So if you want to have, basically if you want to have a study with an evidence base, you will either want to have a standard care group or a placebo group, which is sometimes not ethically indicated. So there is a need for understanding how to work out that, or how synopsis, topics of synopsis should be.
sir was speaking like research topic in a concerned specialty subjects.
So concerned specialty means, if you ask me regarding research or R&D in medical, I will say it will be drug coding. I would say it will be drug coding because I am interested in my PG in drug coding also, and that is something where you can, in drug coding, what you can do is you can even improve polymer students. We have a lot of evidence and people say there is no point. So incidentally I am just saying that I am now part of the drug coding committee of CCR. So it's the first meeting because there, even though I am the youngest person there, Dr. Tiwari is the chairperson. So he asked everybody what is your idea regarding what to do in drug coding. So I said my humble submission is you should add recoding of polymer, at least 20 drugs which we are daily giving. Everybody is giving 20 drugs or 20 drugs daily. These should be recruited and in Indian conditions and in that way. So these are all good in Europe. We have a lot of data there, but we are just applying this and we are saying sometimes it likes, sometimes 30x, sometimes 30 doesn't like. And we are trying to just find this limit. So none of these are recruited. So now I think this year we have included this as a part. And we have said it will be all after a lot of deliberation, discussion, and a lot of convincing, I think from every group, from a Medica group, from a also country like that, they are trying to do. So if you try to do that, at least the student will learn much more than all these exercises. If you like, if you are part of the curriculum of Parsatla and you develop some systems of Parsatla, automatically you will learn. And the practitioners will be interested. Because practitioners are using these drugs daily without actually having first-hand knowledge. If they are part of this curriculum exercise, they will be definitely involved in this, and that will, I think, boost the whole system. So that is one thing I would say. All can CCRN is basically doing proving of small, very small remedies, which at the end has no consequence. I don't think you can prove a remedy till it becomes a body presence which has no condition. So we are proving azathiopril or some allopathic drug and proving it again and again, and you are not getting any. So you know something which has a definite wide sphere of action as a body presence. If you try to prove it, then that will have a lot of value. If other topics, I think this is one thing which you can do, but again there is a problem with like when I did my proving, there were now stringent rules regarding this introduction of new drug in the system and all. Now if you want to go for a proving, I think definitely you have to go to the DGCI level for getting the approval. Now I think the COVID also, he has been running out more outlets. It's a very difficult thing to do. So even for a PG student, it's not so easy to start that. So we have to think of topics which can be done So I think the research methodology people will be able to help. They are the only people who can. And another thing is research methodology should be on homeopathic ideas. Basically, research methodology we try to adopt all the other homeopathic concepts in research methodology and directly apply to homeopathic ideas directly in there. And if you are not able to show actually what we are doing. So we have to understand research methodology in our terms, understanding how we can incorporate in our system. Other topics if you can give any guidelines or any inputs regarding synopsis, that will be good. What are the topics are we using in here? Media group and media group in any particular therapeutic condition or? So media group means how we, it's a clinical study. So we have a therapeutic, or you have all the medicines of media group listed out? So how do you do it? But again, if you take Wikipedia, how many will actually? So can you give the conclusion of the understanding you have allow this similar medicine? Comparison.
One medicine.
So what do you do then? Calculate.
Also, we do mostly clinical similar, but there are ethical issues in doing that for a particular drug for a particular condition or even a group. So you will find, so you will be recruiting lot of patients who are not pulsate lab, but we are conducting a study on pulsate lab. Right, so that is actually a city not so. So we are trying to get around that. Or even a group. So we have students do Bulgarian group in thyroid. There will be severe patients, there will be other patients, iron patients in that. Or ideally you should take case and exclude all those iron patients. But that will be really.
You will not be able to get the sample sizes.
Yeah, so this issue is always there. Only clinical thing you can properly do is individualize homeopathy. And then it will be
So you have to come back to utilize homeopathy.
Or some specific medicine which has got specific similarity. There is one of my students are doing on there is a rare remedy called Ilex paragensis. There are a lot of studies on nocturnal illnesses. So he is doing a comparative study on Ilex versus individualized remedies. But then you need studies to back that up, because this luckily we have found studies which showed effectiveness of this remedy, then it was ethically all.
But like when you go to the research people, sometimes they say that if you already have studies to back up or you have studies already done, then why are they taking up this study?
Yes. So this is a comparative study. You are comparing Ilex with whether our Materia principle individualized homeopathy is superior. But whether this specific remedy, whether that is the thing.
This year I have asked one student to do study of migraine. So individualized homeopathic medicine on one side and only Muller has seen that. It breaks up the sick headache habit. So breaking up the sick headache habit means that is something which a constitutional remedy can do. So I am trying to, like, I don't know, IEC has not said whether they approve it or not, because none of the other books I can see that particular line. It's mentioned for different types of headaches, but breaking up the sick headache habit means that is definitely what a constitutional remedy we expect from a constitutional remedy. So if this can be compared. So I am just again going to see. So I think this again is a topic where we have to have a lot of, I think what Ma'am was saying, we should have a group and where we exchange some ideas, and some research people are also on the group, where we can crush out all this, we can give these ideas and see what is feasible. What is feasible through research and what can stand the test of time. Because the problem is if you go to take a study and you go to the ethical committee, if you reject it first and foremost, then there is no point in obligating the study. And I think all CTRI, once you do it, then the student can directly go for the
New regulation it is
publication. It is mentioned also.
mandatory.
But CTRI is mentioned specifically.
Yeah, CTRI is
Mentioned.
mandatory. The regulation.
That's good.
So one small thing about the
Yeah.
the thing is about the general topics. Somehow they made it little bit more complicated is what I feel. Because now they split it into part 2 also. So part 2 is where how to study Materia. So you have a case where the student has to study Sarfat Kalkari like a podium
And then study.
and then study how to study Materia. Right? So I think the old syllabus in that sense was much sensible in that basic Materia was in part 1. All these things was in part 1, then you apply whatever it is there. I don't know why, what is the logic?
Some repetitions are also there. Repetitions are also there.
Same.
This is, I think, a first attempt, so I think maybe it will be modified, come out and some more better way. The main part is the implementation part. That is the most difficult part. UG teaching for the students. So that was a topic which we discussed earlier.
So they said this curriculum is for 5 years and then will be 5 years and then they will be repeat. I mean 5 batches of PG students will be like
Starting.
yeah. They'll be experimented upon. 5 years PG. 5 the syllabus
At the end of
then they will be making changes.
They'll achieve the last competency or the level. Yeah, I think this year.
Already dispatched, already started.
State delegation also over there.
Thank you for your